From Microbe TV, this is TWiP, This Week in Parasitism, episode 112, recorded on Thursday, the 23rd of June, 2016. This episode is brought to you by CuriosityStream, a subscription streaming service that offers over 1,400 documentaries and nonfiction series from the world's best filmmakers. Get unlimited access starting at just $2.99 a month. And for our audience, the first 2 months are completely free if you sign up at curiositystream.com/microbe and use the promo code microbe. Hi, everybody. I'm Vincent Racaniello, and joining me today are Dickson Despommier.
That's two people, Dickson and Despommier are. Hello, Vincent.
How are you, Dickson?
Hello, Dr. Griffin.
And Daniel Griffin.
Hello, everybody.
It's a beautiful summer day here in New York City.
It will.
You don't think so?
Look out the window, Vincent. I think it's a little cloudy right now.
Yeah, you're right.
It's predicting showers, but
Yeah.
It's still nice. It's still not bad.
Yeah, there may even be some electrical activity later. We're
Some
worried about that.
Electrical activity.
I worry about that because it compromises our Thursday night sailing races.
Well, guess
that's
what
a
happened
problem.
in India recently?
What happened?
Like a couple of days ago, the monsoons have started,
Really?
and 70 farmers have been killed by lightning strikes already in just 2 days.
Wow.
That's an enormous number of people, and a lot of thatched roofed houses have been caught on fire, so people are really scrambling. This is in the easternmost portion of India.
Is that typical to have a lot of
No.
electric? Yeah, that seems
It is
odd.
not typical. So this is another manifestation of an odd monsoon season. I'm sorry to say that, but
Was this attributable to global climate chaos?
no. Well, some people would like to attribute it to that, but it's still an odd weather pattern to experience for the beginning of the monsoons, unfortunately.
Well, speaking of monsoons,
Yeah.
we have a case from TWiP 111.
And there was a lot of watery diarrhea.
That's
Is that
right.
what brought you?
Very good.
A monsoon amount of watery diarrhea.
Exactly
Right.
what I was thinking.
Excellent.
Shall I start by reminding everybody?
I
And
would-
as I say, acquainting people who are just tuning in. Last TWiP, we presented an 82-year-old woman who was living here in Washington Heights. That's the northern part of Manhattan. And she had come into the hospital with 10 days of watery diarrhea. She said that this was not smelly, that she didn't have solid floating parts that were coming out. She said that the diarrhea was continuing and waking her up at night. No fever, no sweats at night. She had lost some weight. Her appetite was down. She reported, she says, no recent travel. She was born in the Dominican Republic in the early 1930s. She moved to the U.S. at age 30, right? So like 80 years ago.
Yeah.
So she's sometimes she goes back, but she's not gone back for several years. This is occurring in the springtime. As I mentioned, it's a recent case. She lives with her extended family. Only one of them is sick. She's the only one. She eats a whole assortment of cooked foods, rice, beans, fresh fruits. She drinks tap water. She's currently not working, doesn't have any pets, stays mostly inside. There is a history of reflux, high blood pressure, a little bit of cognitive decline, and she had recently been diagnosed with temporal giant cell arteritis, for which she had been put on prednisone, and she's doing better as far as that goes. She did have her gallbladder removed. She's HIV negative. Her extended family works in the city. There are no taxi drivers among her extended family.
Wait, remind me why.
Why did that come up? Does anyone know why that came up? I don't know why that
Totally forgotten. Taxi driver.
maybe there was some...
Oh, bringing infections into the home, I suppose. Yeah.
Okay.
Because she didn't go out. That's it. She didn't go out, but her family could go out and come in.
So it's an issue. Okay, that makes sense. She did say that she's had a little bit of belly discomfort for about a little bit over a week. Her temperature was elevated at 38.1, so she had a fever. Blood pressure was fine. Heart rate was 105. She was breathing comfortably. On exam, she looked ill. She had a diffusely tender abdomen, decreased bowel sounds. Liver and spleen were not enlarged. She was oriented And remarkable was that on her abdomen was a rash. It was an odd, patchy distribution. It was peri-umbilical, so extending out, and it looked like multiple thumb prints. Did we use the comment thumbprint purpurer maybe?
Might have.
On the front of the belly. She had a white count of 8, 78% polys, 14 lymphs, 4 monos, 1 eosinophil. That's 1%.
Yep.
We discussed that something was interesting about that. Sodium was a little low at 129. Her BUN was 15, creatinine 0.6. She had a urine histoplasma, which was negative, and a TB test that was negative.
Right.
And
Are you surprised that she's TB negative?
You know, I would say that, well, maybe this is a bit of a hint, like here's a woman on steroids. So, and maybe the dose of steroids was enough to make her TB negative. Mm-hmm. But do I think she's been exposed? Is it unlikely? Would it surprise me that she had never been exposed? That would surprise me.
Yeah, I thought so.
I'm going back and forth to the Dominican Republic, an area very indigenous. And when you go
she lives in Manhattan. I mean, just go on the subway.
Actually, that's true. Yeah, no, we actually, interesting. Where are the hotspots of TB in New York City? Yeah. It's actually the highest number of cases is Queens, and the highest density of cases is an area of Brooklyn.
Interesting.
So stay here, stay on the Manhattan Island, be safe.
Yeah, here you'll get.
No, I said just breathe out.
It's all right.
You get something else here, right?
You should just breathe out.
No, there's plenty of TB, and no, I think the number was last year. We only had a total of 20 cases of TB seen here at Columbia.
Yeah.
So, that's much better than I remember 20 years ago when I was at Bellevue.
That's absolutely right.
By the way, before we move on here, I just wanted to let you guys know, because this is relevant to parasites. I was at the American Society for Microbiology meeting last week, which took place in Boston, Massachusetts.
Yeah.
And the keynote speaker was Bill Gates.
Right.
And I sat in the front row.
Huh.
I'm going to show you a picture for which I'm going to move away from the mic.
There's Bill Gates.
How about that? And who's he sitting with?
He's a medical reporter.
Right.
I forgot his name. But he was really sharp. He has a foundation, of course, to which he donates a lot of money. He doesn't just give them money. He actually gets involved in what they do.
Right.
They have all kinds of health and immunization programs globally, including malaria and polio eradication and many, many others. I was impressed at how smart he is.
His wife is pretty smart, too. But
I think she's smarter than him, I was told.
Isn't that usually the case?
Yeah, right.
Let's all be honest.
That's a woman on steroids.
So, he said the biggest problem, in his view, is malnutrition, more than any infectious disease. He said in parts of Africa, he said kids are so malnourished that it makes them more susceptible. If he could tackle that, he would.
Well, I would raise my hand on that one.
What do you want to do?
Well, I heard some interesting reports. I was away too, in Europe, mostly in Stockholm and then to Amsterdam, and I heard a lot of people talking. This was a Eco-Cities meeting in Stockholm, and then a vertical farm meeting in Amsterdam, and then followed by a trade show called Green Tech, where all the indoor growers showed up, but a lot of other people came too. And I heard a lot of comments about this technology, the indoor growing technologies, can empower people that are really malnourished, and as long as it's cheap enough and robust enough so that it's easy to do, like driving a car or something like that, which everybody can do. So they thought about Africa. They thought about
Are there indoor farms in Africa?
Not yet.
They're not going to afford to build a new building, but they can repurpose.
Yeah, that's
buildings, right.
That's right. Well, the shipping container industry.
Shipping containers.
Well, no kidding. No, there were a lot of repurposed shipping container iterations of indoor growing systems.
Yeah. We talked
so
about that
they're all over the
time.
place, and put them to use.
I just put up our last urban agriculture, and at the end, I said, "Hey, Dickson."
Yeah.
And you said, "What? I'll see you in the shipping container."
Exactly.
Okay.
Right.
We have
That's where I've been ever since.
Good. We have a lot of case guesses. The first one to come in was from Hannah, who writes, "Dear Doctors TWiP, my guess for the most recent case study is disseminated strongyloidiasis. A Google search for thumbprint rashes led me to articles about periumbilical thumbprint parasitic purpura, the thumbprint sign being a diagnostic criteria for disseminated strongyloidiasis in immunocompromised patients.
Yeah.
That led to a Google search for prednisone, which, as I suspected, is indeed an immunosuppressant. Dissemination can occur decades after initial infection, which in her case most likely occurred when she was living in the DR. Although the symptoms listed on Wikipedia don't match 100%, chronic diarrhea is on the list, as is a loss of peristaltic contractions, which may explain the decreased bowel sounds. Prognosis is very poor, so I hope I'm wrong, but I've enjoyed trying to figure it out. Thank you so much for everything you do. I'm a big fan. All the best from Berlin.
Nice.
Anna. All right. Daniel.
So I'm going to start. Dr. Wink writes, Dear TWiP professors, I'm aiming to tie my previous case diagnosis record of 1 in a row. Here goes. Profuse diarrhea with dehydration should make you think of cholera. I'm going to guess that there are markets of food from the DR in Washington Heights, that someone snuck in a product from Haiti into this market, and that our patient ingested a marine food with V. cholera attached to its chitin, imported from Haiti. The Public Health Service inadvertently reintroduced cholera to Haiti during relief programs. This followed a 100-year absence. My second guess is cryptosporidiosis, because her steroid therapy for temporal arteritis may make her susceptible to more severe illness. I don't get the rash. Wink, Weinberg, Atlanta. All right, Dave writes. We're going to let Dickson read this.
Dave, I'll reiterate. Dave writes, Dear doctors, the 82-year-old woman seems to be presenting a case of entamoeba histolytica. Her inflammatory diarrhea is possibly due to the parasite's damaging of the intestine, and as a result, she has been afflicted with weight and appetite loss. E. histolytica can also form skin rashes, and while her liver and spleen may not be enlarged, if the disease is indeed amoebiasis, she should still get this treated as fast as possible to avoid the formation of liver abscesses. I surmise she contracted the parasitic disease from a careless food worker somewhere in Washington Heights, an area with a population quite high in Dominicans, probably including recent immigrants. Thank you once again for the informative podcast. Sincerely, Dave P.
He's right about the neighborhood. Why do you think that people from certain areas go to certain neighborhoods? It's a numbers thing, I guess, right?
I think you know people, right? If you were thinking of moving to New York and someone said, "Oh, I'm living here," you might think to look there. And
are there other areas that have specific types of people who have come from?
No, New York City is a series of small ethnic groups which are juxtaposed next to each other. You have Chinatown, you have Little Italy, you used to have Germantown.
You have the Russians in Brighton Beach.
In Brighton Beach.
Little Italy is shrinking. What's going on, Vincent?
It's true. Yeah. Hey, let's get on the stick here.
They're not coming here anymore.
No, they're not.
You know, the nature of the immigrants has changed. My father and my mother's parents all came from Italy, last century.
Yeah.
And tons of them, Irish and Italians and many others, Polish. Not
Asians,
as many, not as much from Europe, mostly Asia, right?
And Hispanics.
Exactly.
Exactly right.
But we welcome them all.
Absolutely.
In contrast to
except Donald
some people who don't. They have made this country from the start.
Correct.
Ridiculous.
And will continue to do so.
That's right.
Some of my smartest medical students, by the way, were immigrants from Vietnam.
I'm proud to be a first-generation Italian. Italian. The next one is from AJ. Hello, Team TWiP. In regards to the 82-year-old female with the watery stools, I'm at a bit of a loss. A water loss?
Good one.
You rehearsed that.
I didn't. Presence of a rash is throwing me off. I've heard that ascaris can cause rashes, but with her eosinophils in the normal range, I'd rather lean towards intestinal protozoa over helminths. Giardia can also cause a rash, but that would result in a fatty, smelly stool. On my list of candidates, entamoeba histolytica, Balantidium coli, Cryptosporidia, Isospora, and Cyclospora. I think the best guess is Cyclospora, but I haven't heard of it causing a rash. She could certainly have acquired it in the U.S. rather than having a very delayed onset if she acquired it in the DR. E. histolytica would be my second favorite of the bunch, seeing as it can cause a rash, but I would have expected to see blood in the stool at least occasionally, and the same with B. coli. Isospora seems rather rare, and cryptosporidia is usually asymptomatic, and immunocompetent individuals, at least self-limiting. Honorable mentions: Chagas disease can cause megacolon, but that should present with a distended belly and other symptoms. Cholera causes rice water diarrhea, but is of course not a parasite. I don't believe it's common in D.C. anymore, though. D.C.
Dominican.
D.R.
Right. Dominican community.
To diagnose, check for cyclospora or other cysts, eggs in the stool. I'd also run a stool antigen test for E. histolytica. Since the cysts are morphologically identical to each other, non-pathogenic amoebas, I'm certainly looking forward to hearing the answer, and I hope the patient fully recovers. Thanks, AJ, parasitologist, hopeful in San Diego, where it does get slightly cloudy in the spring. Right.
Okay. Yusuf writes, Dear TWiP Trio, sorry that I haven't answered for a while. I just finished my second year in medical school and am about to start my third year. It's possible that I will even see Dr. Griffin in some of my rotations.
Nice.
Yeah, he might. You know, I was seeing patients out there, and I've been talking to people about trying to do some clinical work out there again.
Okay.
So there is a possibility. For my diagnoses, primary, I am going to guess that this is a case of strongyloides stercoralis infection. While the patient does not have an elevated white count or an eosinophilia as expected, this may not be necessary if she is being immunosuppressed by the steroid use. Many people can be chronically infected with strongyloides for years and be completely asymptomatic until they lose their ability to fight back and the infection disseminates. The key clue in this case is the periumbilical thumbprint rash, which, when I searched for, came up with strongyloidiasis. I would order a stool and ova to confirm. Ivermectin and albendazole could be used to treat. Secondary, ascariasis can present similarly to a strongyloides infection, and I don't think it can be ruled out completely by the history. The stool and ova would help confirm if there is co-infection and would help to rule out ascariasis. Tertiary, other parasites such as Cryptosporidium parvum or Cystoispora belli are also possibilities that need to be ruled out. They can both cause diarrhea and can tend to be worse in an immunosuppressed patient. However, did not believe that they are associated with a specific rash, and the patient's history never mentioned possible contact with fecal contaminated water. Non-parasitological causes. Campylobacter enteritis can cause rashes and GI symptoms, possibly obtained from undercooked poultry. Overall, I'd probably give her some IV fluids, electrolyte supplementation, and order a stool and ova along with the stool culture. One question that I have is, how tolerant are people to chronic administration of ivermectin? I would expect in this patient, since she's already has a history of cognitive decline, that their neurotoxicity of ivermectin might be a greater concern. Sincerely, Yosef Davidoff, Hofstra Northwell School of Medicine medical student, class of 2018.
Listen to that. Sounds pretty good for a second-year medical student, I tell you.
That must be a good medical place out there, right?
Especially if they haven't had a course in parasitic diseases. But you can read the literature, that's for sure. So Alan writes, sorry I caught the gap between your TWiP recording and the posting last week. The weather today in Myanmar is 32 degrees C with 88% humidity. Sounds very pleasant. Not too many things cause the described periumbilical thumbprint purpura, the most likely being a strongyloidiasis hyperinfection. Anyway, that's my guess, and I'm sticking with it. At 88% humidity, I'm sticking to everything this week. Keep up the great work. Alan Robbins for the U of N Global Health Consortium, I presume.
Jamie writes, Dear Vincent, Dick, and Daniel, greetings from Caracas, Venezuela, a city where weather is balmy and pleasant most of the year. Our current temperature is 21 C, annual average temperature 24, with no rain for the next couple of days. As an infectious disease-trained medical specialist working in the tropics, I do enjoy thoroughly all your podcasts, which find not only informative but most entertaining. Your last clinical case of an 82-year-old woman living in Washington Heights with watery diarrhea and an abdominal rash resembling multiple periumbilical thumbprints represents a diagnostic challenge even to widely experienced clinicians. Periumbilical thumbprint purpura is a rare but pathognomic manifestation of disseminated strongyloides stercoralis hyperinfection in the immunocompromised host. The patient has a recent diagnosis of temporal arteritis, a condition that usually requires high doses of corticosteroids for initial treatment, the latter being a well-known risk factor for disseminated strongyloidiasis. She is from the DR, presumably from a rural or peri-urban area, an endemic country where strongyloidiasis is endemic. This parasite has the capacity to produce long-lasting infections due to the mechanism of autoinfection, whereby infective filariform larvae may penetrate the intestinal mucosa or perianal skin and perpetuate the infection in the host. Although eosinophilia is a common feature of strongyloidiasis, it is typically absent during the episode of hyperinfection or dissemination. Since disseminated infection entails migration of larvae beyond the pulmonary and GI tract, this is often complicated via bacterial gram-negative sepsis due to translocation of intestinal bacteria. Diagnosis is made by the documentation of increased number of larvae in stools and their occasional finding in samples of sputum or even CSF. Lethality rate for disseminated infections may be extremely high, over 80%, unless prompt and effective antiparasitic treatment with ivermectin is provided. Again, thanks for your excellent work with TWiP, Jamie Torres, MD.
Nice.
Very good.
It's very thorough.
You bet.
Very.
Mark writes, Dear TWiP team, it is 105 degrees Fahrenheit at Oklahoma G Festival today. Suspect patient has cryptosporidium infection brought on by immunosuppressive prednisone therapy for giant cell arteritis and New York drinking water. Sorry, but I remember a comment by Dickson regarding New York drinking water. It can't be that bad, can it? Hope you stay cooler than Oklahomans this weekend. He actually gives us a link to what looks like a really interesting paper. Maybe we should discuss that this week. Helminth infection promotes colonization resistance via type 2 immunity.
I don't know.
That's our
It's
paper,
something about
Daniel.
nod 2.
It's not him. It's us. It's
Oh,
our
is that
paper.
us? That's
Yeah,
our
yeah.
paper?
Yeah. I put the link in.
So we should.
I guess if we suggest it, we should probably discuss it.
Dixon, I thought
Yes.
New York City water was fine.
It is, but there are seasons during which you can find on a 10-gallon filtration experiment some oocysts from cryptosporidium, which emanate from New York State's watershed. So
Yeah.
this woman had this occur during the spring. It's remotely possible, because she drinks tap water, that she could have acquired cryptosporidium, but the telltale symptoms are, I think, contrary to that diagnosis, in my opinion.
What's the origin of those cryptosporidium?
They come from cattle.
Cattle?
Yeah, that's mostly cattle. It's a big dairy farm industry up in the southern tier of New York.
It
We
certainly
actually have
is.
some of the
As
best,
you will know, because you went to Cornell.
I do.
yeah, we actually have some of the best drinking water.
We do.
in New York City, because it's all runoff. It's not coming out of the ground where it can become contaminated, where things can. That's a problem in Long Island. There's been so much industry.
Okay.
We have an aquifer that'll last hundreds of years, but things are seeping down into it.
Yeah, they are, aren't they?
And what
Ethylene chloride
is
and stuff.
this? Grain alcohol and rainwater are the only things you should drink? There's a movie about this.
Well, you can get both of them in the aquifer of Long Island. How's that?
Yeah, so we're drinking rainwater here in New York City.
Right. So runoff, that's what we drink. New York City drinks runoff.
All right. So what else do we need to know about this case, Daniel?
How about some diagnostics?
Well, the emails were great. I like I like the fact that people gave us differentials. I thought that was nice. That people went into some of the details. People addressed the rash. I mean, I threw the rash out there. Hopefully, that was going to be something people could get their teeth into, as they say. I also wanted to make a point of what's the story with the eosinophils. How do you reconcile what you start thinking about with the rash with the fact that there's only one eosinophil? And the other thing is, I wanted to point out this person was really sick.
Right.
And I wanted
10 days of watery diarrhea.
Yeah, and I want to draw attention to, let's see where the person put this, about someone mentioned a gram-negative bacteremia as well. Remember that?
Excellent other point. I agree.
So I'm going to tell you a couple things that we did. This person is really sick. And when someone's really sick, you send off a bunch of tests. One of the tests we sent off was blood cultures. We wanted to make sure that though we had in our mind from this characteristic rash what it could possibly be, we had a consistent story, we also wanted to make sure that it wasn't just one thing, that if there were two things. Right. And that also tied in my mind to the lack of eosinophilia. So we'll get so now that I'm sort of throwing we're going to do a bunch of tests. We're going to do blood cultures.
Good.
We're going to send the stool off for a bunch of tests.
Right.
We're going to biopsy the rash because this woman's sick.
Good
and
idea.
We need to know.
Great idea.
We need to know now what is wrong with this person.
Oh, let me ask you another question though, because you gave a CBC, a complete blood count, and a differential, and the differential didn't really reflect a bacteremia as far as I could tell. You didn't say anything about shift to the left neutrophilia, which I would have expected in a bacterial infection.
Yeah.
Is that true?
Well, yes and no. So we did have,
which part is yes and which part is no?
So it's interesting in that usually when someone is septic with bacteremia, we talk about a left shift, right? We talked before. That's you have more neutrophils or polys, as people describe, and you tend to become eosinopenic, right?
Correct.
You tend to lose your eosinophils. This person has eosinophils.
That's right.
So what I'm going to just one, but still, and that was something I never really heard the common use of until I was in India, and they were always talking about, oh, this person has eosinopenia. And that was their comment about they're really sick. They have some sort of serious infection because you're getting, their left shift is it's so shifted away from the right where the eosinophils are that there's none left.
Exactly.
And here's a woman on prednisone. Prednisone will clear your eosinophils.
Yep.
You'll put someone on prednisone and you don't see any eosinophils. This person is on prednisone with an eosinophil.
Exactly.
I thought that was interesting. So I think you're running into a balance here. I'm going to go ahead and tell you, in addition to our parasite, this person grew E. coli from the blood.
Roger that.
So they were bacteremic, and that grew pretty quick.
Yeah.
Pretty quickly. So they've got, somehow someone has this rash, they've got everything going on, and they have E. coli gram-negative rods in their blood.
Yep.
And so does that kind of cinch it for you, Dickson? Do you
does,
feel like you know? And what would
we
be...
used to teach this subject, so this is a classic case, actually. We had slides from a similar case from every organ, and it was all positive for the particular organism that we're going to be discussing.
Yeah. And what stool test would you send?
Well, you have to be careful with this one, because if you want to culture, you can culture this organism along with the bacteria, and you can actually run into some problems because the organism can then crawl out of the dish if it happens to be the one that I'm thinking about, of course. Yeah. So the technician is at risk. They do something called a Behrman sedimentation test for a particular parasite where you have very few of these organisms present in the stool, but if you take an entire 24 hours worth and sediment it and then look at the sediment, the chances are that you will find what you're looking for.
Yeah.
So
Dickson's actually right on this. So in the stool there was actually
right?
there was larvae. There were actually motile larval forms, which is interesting. Normally we think about parasites doing, the ova looking for eggs.
Sure.
But maybe that's what they call it, ova and parasites.
That's right.
So it's ova and larvae, maybe it should be an ONL. I'd like an ONL.
Yeah.
So there were little tiny nematode larvae in the stool, and on the biopsy of the rash, you could see little larvae in the rash biopsy.
So the case that I'm most familiar with was diagnosed by a dermatologist. He was a super guy, too. His name was Greg, and I'm blocking on his last name, but he was an amazing dermatologist. He was like the chief resident or something like that at the time. And there was this broad rash that occurred over the belly of a patient that was similarly and what you're looking at is actually the larvae going through the large intestine and then through the omentum and then through the wall of the stomach, or the stomach wall, rather, the abdominal wall. And then into the skin.
Where are they trying to go?
Anywhere they can.
They want to get out?
They go everywhere.
Are they trying to leave?
Well, they're going everywhere. So that the ones that they go in all directions. So the ones that happen to go up forms this rash. And it's an unusual rash.
Wow.
As you mentioned.
Yes, and so the answer, just for everyone listening, is this is strongyloides.
Yes.
It's disseminated strongyloides. And there's two classic rash forms. There's the rash you hear about, which is the running larval forms, which is the larva curans, the racing larva rash. And you can actually watch this rash develop on a person because the larvae are moving fast enough that you can actually see the red streaks extend over like an hour. Draw with pen, come back an hour later, and they've actually moved a centimeter or more. And that it tends to be, as Dickson is describing, in the abdominal area, because it's actually, they're disseminating in the intestines and they're actually coming through and into the skin.
And that's the source of the E. coli.
And there's also, we're going to get into that.
That is what they eat.
So the other is this, what we talk about is this thumbprint purpura.
Yeah.
And it actually tends to be, we're not sure of the exact details, but it tends to be an inflammation, a purpura, a leaking of blood out of the vessels. There aren't actually, as we see, there are some larvae involved, but it's not the actual larvae moving along. It's a reaction to the larval infiltration. Mm-hmm. But the E. coli is an interesting thing. How does the E. coli get in? You got to realize these are animals that are penetrating the gut wall. And once they penetrate the gut wall, they get into you. And let's say you left, I use this example. What if you left your dog in the house for several days with all the doors shut? What would he do in your house?
Poop.
Exactly. And so these are animals that eat E. coli, that have E. coli in their, they're actually releasing it in their excrement inside of you.
Yep.
And so in addition to perforating your bowel and breaking down the integrity of that barrier, they're bringing it in. And we've actually seen, in last year, we saw a case of a E. coli meningitis in a woman with strongyloides. And so all the E. coli is getting in, and when they're going into the CSF, they're bringing E. coli with them.
Exactly. The other point to make, I guess, in this regard is that you can think of the second stage larva, which is the one that breaks out of the gut tract where it's laid as an egg, then develops the first stage, and then molds to the second stage. The second stage larva breaks out into the intestinal lumen, and under ordinary conditions where you're not immunosuppressed, they would pass out of the gut and start the cycle outside the host.
Wow.
Yeah.
But in this case, because the host is immunosuppressed, the parasite has the option for developing further before it exits the host. And in order to do so, it has to grow. So the second stage larva has to feed. And what does it feed on? It's in the large intestine now, and it's feeding on E. coli and all the other debris and all the other microbiome players as well, by the way. So sometimes it's a Klebsiella, sometimes it's a Pseudomonas, sometimes it's an E. coli, sometimes it's a that sort of thing.
Yeah,
but
tend to be gram-negative rods.
The exciting part of this, and not so much for the patient, of course, is that when the parasite develops to the third stage, it's an unfeeding stage. That doesn't eat. So in order to become a third stage worm, it has to clear its gut tract and molt. And when that happens, of course, it could happen not in the lumen of the small intestine or the large intestine. It could happen in the tissues, right? As this worm penetrates as a third stage larva, it's defecating all of the meal that it took in as a second stage. So it's a little micro needle that's injecting bacteria all throughout your body.
So does the disseminated nature only occur in immunosuppressed people?
Yes, I think I can say that confidently. It only occurs in immunosuppressed. Different types of immunosuppression make you more susceptible. Mm-hmm. So I think a viral infection, HTLV1, something about that immunosuppression makes people not only super susceptible to strongyloides, but really hard to ever treat them.
Okay. Now,
prednisone, getting into what Dickson just said, not only does prednisone immunosuppress you, but it also looks like it accelerates the molting time. And so they quickly go to the second stage molt before you pass them out.
It shows you how much control your immune system has on the development of this worm. That's the point.
Yep.
And so when you relieve that control mechanism, the worm just takes off. In
this woman, the rash was around her umbilicus, right?
Yes.
And now could it go elsewhere? Could it have spread upward?
It is.
So the strongyloids is spread everywhere, but the rash you see tends to be prominent in the abdominal area.
Do we know why?
We believe it's actually the direct extension of the larvae to those zones. Now, some of the larvae will get elsewhere, giving us some meningitis, but the rash we're seeing is a heavy burden. I mean, you do a biopsy and you see little larvae everywhere.
So it can get in the CNS too?
Oh, yeah.
Unfortunately, it does.
And that's bad, right?
It gets everywhere.
It really tends not, so the larvae is going to, as we talk about, undergo their molting. It's the fact that they then get in there and they're bringing gram-negatives into the central nervous system.
So in our patient that we used as a teaching tool, and by the way, the case history was like 10 pages long because she came in for several reasons. The first reason was diverticulitis. So the patient that we taught said, this woman had diverticulitis. Diverticulitis allows you to maintain low levels of smoldering strongyloides infection over years because it's a pocket in which the organism can actually develop away from the influence of the host, basically. And so you have these little pockets in your gut tract all the way down, and you get inflammasome activation and all kinds of other things. But the worm can smolder. So that's an auto-infectious, non-hyper-infectious process. And so how long do you think she had this infection?
Well, I think that's that's a great thing I wanted to make sure we discussed, is that most parasitic infections, you get an ascaris worm, that's it. You have one ascaris worm. Let's say you get a pair. Well, they may make eggs, and they may make lots of eggs, but those eggs are going to pass back out. They're not going to complete their life cycle inside of you.
Right.
The strongyloides can actually have this auto-infection where it creates it goes through its own life cycle and multiplies in a host.
Indeed.
And so, did she have this for 80 years? She could have, actually. That is possible.
Could have.
Undergoing whatever, auto-infection cycle. Or she could have had this for 5 years, 10 years, 20.
You mentioned she had pets.
Did she have pets? I don't think she did have pets. You're going to bring up the dog issue?
Yeah.
Okay. Bring up the dog issue.
Okay.
Go right ahead.
No pets.
Cue the dog.
No pets, yeah.
All right. So, but if she had a dog, it's possible that the dog could have had an infection also, because this is not a human parasite per se. It's got a multiple host system. So veterinarians working in animal laboratories at research centers were highly susceptible to these infections before they were aware of the fact that they should treat the monkeys with anti-helminthics first.
Yeah, actually, the gorilla strongyloides is actually very pathogenic in people, the chimps and the gorillas. And we had a case here in New York not so many years ago where it was the daughter of a gorilla researcher. The daughter ended up with, the strongyloides it was actually a gorilla strain.
How about that? By the way, what's the old term for this disease? That would have been a tip-off also for the symptoms. She only had one major symptom besides the rash, and that was a sign, rather. So her symptom was that she had watery diarrhea, right?
Yeah.
So watery diarrhea, this infection was known for many, many years as Cochin China diarrhea.
Oh, yes.
And it was discovered by two French physicians working in Cochin. And I tried to look up where Cochin was. Now, Cochin is in several places on the map. One of them is in India. Another one is in Indochina, which is now Vietnam and Cambodia and Laos. So finding where Cochin really was in the beginning is a difficult issue. But nonetheless, a lot of patients over there were suffering from this disease. And so they came to name it Cochin China diarrhea. So that's the number one symptom from an overwhelming infection with strongyloides, which in normal people lasts for about 6 weeks, and then your immune system kicks in and it goes away.
Dickson, how did she get it?
She got it by being exposed on the surface of her skin to a third stage larva. It actually penetrates the third stage through the unbroken skin, but strongyloides has the option. You can swallow it also as a third stage larva, and it'll infect your mucous membranes in your mouth.
And the skin infection, she would have acquired that from what?
You mean the rash?
No, you said contact.
Oh, yeah. So she could have sat on some grass, in a park someplace down in the Dominican Republic where dogs are allowed to defecate at will, or an unsanitary situation where human feces is also not well controlled. And as a result, that's how a lot of people do catch it.
Stay out of the parks.
Well, you should put some clothes on at least, or if you but people wear shorts a lot, and they put their legs down on the grass and stuff like this. So it's very common in many tropical regions to catch this routinely.
Well, there's the issue right here in the States among the coal miners, right?
Oh, well, coal miners.
So here are the coal miners. You're in the coal mines, we'll say West Virginia, and you're in there all day, and you got to defecate. Where do you go? You're going to hoof it back out, use the latrine. So they'll go there and they'll drop their shorts. And then maybe later on someone will sit. So they actually can get penetration,
right?
In their bare behinds or, where they might sit.
Yeah.
Oh my gosh.
Yeah.
Or if their shoes are, worn down and there's some holes in the shoes.
Yeah. So we do have some endemic areas here, even in the States, of strongyloides.
Yeah, absolutely.
How did you treat her, Daniel?
So interesting. So she had a lot, right? As we noticed. So we treated the gram-negative rods with antibiotics,
right.
And then we actually started her on ivermectin. And she was on a long course as we were tracking the stool larva counts.
Right.
Wow. And she's taken a lot of medicine. And then once the larvae were gone, we treated her for 2 more weeks of ivermectin. And she did well, actually. And I think that because it was only steroids, so the immunosuppression was reversible. What really is a disaster is when we get this in someone like an organ transplant patient.
Yeah.
What are you going to do?
That's right.
So you took her off the steroids?
So the steroids were stopped, yeah.
And her other issue didn't recur.
So that was actually the fortunate thing, right? The temporal arteritis, she had already gotten, I think, enough of a dose to calm it down. I don't know if we ended up putting her on methotrexate or what we did about that down the road. Of course.
What is the sequelae if you don't treat that?
Yeah, unfortunately, you can go blind, actually. It can extend into the eye. So it is a serious disease.
So someone asked here, what's the consequence of long-term ivermectin dosage? Do you know what that is?
Like neurotoxicity?
I don't know.
I have to say it's actually a very safe.
Yeah,
and that's listed as a
doesn't go
possible
across the
thing.
blood-brain barrier, but the larvae are crossing it like crazy, and they're damaging it like crazy. So it's possible that
It's compromised.
you get a compromised choroid plexus, and the next thing you know, you've got ivermectin in your brain, and then you've got some troubles.
Good drug.
It is
Yeah,
actually, it is an amazing
Did you say your
drug.
wife worked on that, Vincent, when she worked at Merck?
Yeah, much. She worked on it a lot.
Yeah.
She discovered
a Nobel Prize for it.
She discovered the receptor. Yeah, well, she worked with Bill Campbell. They did some stuff together.
Right.
What's she just said the other day? I don't know why we were talking about it, but she said it's a great drug, and you don't have to give that much. You
That's
give
right.
just the minimal doses, and it lasts, and it's effective.
I mean,
if this woman had been treated ahead of time before the steroids, maybe 1 or 2 doses, and this all would have been gone. It would have been prevented.
That's right.
So that's the thing, is to, maybe for physicians out there, clinicians, to realize that if you're gonna immunosuppress someone from an area that's endemic for something like TB, like strongyloides, either treat it or test for it before you do it.
Right.
Remarkable.
1 dose in Africa per year is enough to sterilize the adult female Onchocercus. So that's a long-term infection that can be treated very effectively. Anyway.
Okay.
So
I hope people enjoyed that case.
yeah,
That's very good.
it's an exciting time.
A little bit different. All right, we have a paper suggested by Dickson Donald Despommier, also known as D-cubed. And it's a science paper called...
Yes.
You're going to say yes after everything I say?
Well, only if I agree with you. If I don't agree with it, I'll say no.
Dickson F. Despommier. Helminth infection promotes colonization resistance via type 2 immunity.
Right.
Now, this is an interesting group of people, a number of whom are here at New York University School of Medicine, including the well-known Martin Blazer, better known as Marty, and Ken Cadwell, who has done some interesting work on how noroviruses correct the defects caused by not having bacteria in a mouse gut.
Really?
You'll see this is similar stuff here.
Oh, well.
It's a very cool paper, Dickson.
Well, thank you, Vincent, but I'm sorry that I wasn't one of the authors.
Yeah, it would have been cooler if you had done the work.
That's
right?
true. That's true. But
It makes me think, but my son has inflammatory bowel disease,
well done.
and which is one of the topics of this paper.
Yes, it is.
Inflammatory bowel disease. And this is all about helminths, the immune response, and bacteria in the gut.
Right.
Basically, the basic finding is helminths can reduce intestinal inflammatory responses by promoting the expansion of protective bacterial communities, and they inhibit pro-inflammatory bacterial taxa. What an interesting ecology you have in your gut.
Indeed.
So one of the interesting things here is, Dickson,
Yes.
the NOD2 mice.
Right.
NOD2. I looked up NOD2, Dickson. Did you?
Oh, I used to know what it meant.
Nucleotide binding oligomerization domain containing protein number 2.
Uh-huh.
It plays an important role in the immune system. But here, the key thing here is that mutations in the NOD2 gene have been associated with Crohn's disease.
Yeah, that's right.
Which is a kind of inflammatory bowel disease, right, Daniel?
Yes.
Is that correct?
We have two of the major classes. There's the Crohn's disease,
Right.
and then there's the ulcerative colitis.
Yeah.
So my son has inflammatory bowel disease, and we're going to look at his gut microbiome to see. Because as you'll see at the end of this paper, if it's imbalanced, that could be contributing to it.
Right.
So humans with mutations in NOD2, mutations associated with inflammatory bowel disease. And in fact, in mice, you can delete the same gene, and these mice develop intestinal abnormalities that are dependent on the presence of a member of the gut microbiome called Bacteroides vulgatus.
That's amazing, isn't it? Just one thing can do that whole number.
If you don't have it present, the mice don't develop this inflammatory condition.
Yeah.
Even if it's really amazing.
It is.
And so they wanted to know whether parasites could make a difference. Okay, so they found that if you infect these NOD2 mice with Trichuris murus,
right. Why do you laugh when you say that?
I love that name, Trichuris murus.
Well,
Tricky trichura.
There you go. TT. We used to say TT for.
What's the human equivalent?
Trichuris trichiura.
Trichiura. That's why I'm laughing.
That's right.
Because of the human one. I like.
So the technicians always used to go, "Oh, here's another egg of TT."
TT tricky. So you give mice tricky murus, and it restores their intestinal problem. It fixes them caused by the NOD2 with the wrong bacteria.
Right.
And this is small intestine specific.
Yes.
Daniel, when you have inflammatory bowel disease, let's say Crohn's, where does that occur? In the small intestine?
No, so that's the important distinction, is that Crohn's disease can involve both the large and small intestine, but tends to be predominantly small intestine. Your ulcerative colitis tends to only involve the large intestine, and it can often only involve the rectum and the call a proctitis, an inflammatory proctitis.
Mm-hmm.
So, but there's also a difference in sort of the degree and the depth. I mean, your Crohn's disease tends to be a deeper inflammation that'll end up with strictures and sort of fistula connections. Yeah. But as you mentioned, there is a difference in the regional focus of the inflammation.
Right. So Trichuris murus or Trichuris trichiura locates only to the large intestine. That's its site of preference.
Yeah. Right. Which is interesting. So for some people with severe Crohn's disease, they remove, portion of, you're kind of better off, I have to say, if you have ulcerative colitis. Sometimes you can remove the large intestine completely, and that's the end of the disease activity.
Yeah.
So this regional localization can affect potential therapies.
Yeah.
But what a horrible approach to a disease in 2016 is removing a body organ, right?
Exactly.
Hey, that's what the surgeons do.
This is true. We used to treat ulcers like that,
That's how we
too.
fix things. We take them out.
You're at the Columbia College of Surgeons.
It's actually fishes and sturgeons.
Fishes
and surgeons.
I used to say positions and sturgeons, but that's okay.
Now, these you can also, in these NOD2 mice, if you give them a non-steroidal anti-inflammatory drug, it's called piroxicam, it makes a big problem in their intestine. They develop severe intestinal pathologies. Yep. If you infect them with Trichuria, it prevents the drug-induced problems.
Right.
So Trichuria infection helps both spontaneous and inducible intestinal defects in these NOD2 mice. Isn't that cool?
It's very cool. And by the way, I must say that if we just paused right now and said, now, I wanted to show you an article that was published in the New York Times Magazine section last weekend, in which I would call these street medicine cures, okay? This is not a physician generated series of treatments, but there is an underground of perception that if you are suffering from any of these inflammatory bowel diseases, that if you had a few helminths in your gut tract, that you would be much better off. Okay, because there is some evidence for this, by the way. So this article was written by one of the users of that approach to treating their own inflammatory bowel disease. And I had the good fortune of being able to email Dr. Peter Hotez, who is an expert on intestinal helminths, particularly hookworm, as to what his opinion was about that particular article. And I'm sure that none of us read it, but Peter said he immediately wrote off an op-ed piece to the New York Times lambasting the whole approach and saying that more people are suffering from helminth diseases now than ever before, and why are we busy trying to treat diseases with helminths when we should be studying the mechanisms of those diseases? So that's exactly what this article addresses.
Yeah, we'll come back to that at the end.
Yeah.
Treatment, yeah.
Yeah.
All right, so now what about the bacteria? As I mentioned before, they said this Bacteroides vulgatus is important for the pathology here. So they looked at bacteria in these mice, and they find that Trichuria infection reduces the bacterial burden to the limit of detection. Isn't that amazing?
But only in some group, right? Only in one of those groups.
In the NOD2 null mice.
Right. I mean, I meant, aren't there two groups of bacteria that they were distinguishing?
Well, at this early stage, they just looked at B. vulgatus, and it really is knocked down by Trichuria, Trichuris murus.
There you go. Again, a humorous take on
and the inhibition of growth, by the way, is dependent on lymphocytes. Mm-hmm. So they began to pursue this line of activity, and they found that there were changes in regulatory protein STAT6, type 2 transcription factor, and they find basically that when you infect mice with T. murus, it induces a Th2 response.
Right.
And IL-13 positive, CD4 positive T cells go way up.
They do.
And they also found the same effects with a different helminth, say it, Dickson.
Heligmosmoides polygyrus, or H. polygyrus, as we always called it.
It just rolls off his tongue.
It does. It's a hookworm lookalike, and it lives in the small intestine.
Hookworm.
Yeah, it's not quite a hookworm. It's a
lookalike.
It's as close to a hookworm as you can get without having a hookworm.
So this H. polygyrus also abolished B. vulgatus.
That's right.
And fixed all the problems in these NOD2 minus mice.
Yeah, and restored the goblet cells and reduced interferon gamma plus.
Now, if you block IL-13, you inhibit the clearing effect of the parasite on the bacteria.
That's true.
And if you give the mice recombinant IL-13, what do you think happens?
You can circumvent the need for giving the organism then.
Yeah, that's right. It bypasses the helminth, so that's cool.
Right. So that might suggest a potential intervention strategy for Crohn's patients.
They look at, that's right, we'll get back to that. They look at RNA transcripts that are being turned on, and they find that the IL-13 treated NOD2 minus mice display a wound healing response. Huh. All right. And they say this helps to explain how a helminth infection ameliorates the exacerbated intestinal injury in these mice.
Yeah.
All right, now the next thing, can you put mice together and transfer? Because when you co-house mice, they eat each other's poop.
They do.
How about that, Dickson?
They're coprophagic.
Coprophagic.
That's right. So usually animals do that when they're missing something in their diet.
Is that right?
Yeah.
Dickson, do
but
dogs
I think mice are just standard.
Do it.
They just do it all the time.
Look, I've seen hamsters
they just do it.
Sitting, waiting for the stool to appear and ingesting it the same. It's from a human perspective. Of course, you can't do it from a human perspective, but it's pretty.
So they take unaffected, those are both NOD2 null mice.
Right.
Unaffected co-housed with T. murus infected.
Yeah.
The unaffected get a similar decrease in the bacteria, the B. vulgatus. Now,
but there's nothing transferable from the T. murus infection to the other non-infected mice. That's the point.
Yeah, they say that it takes 35 days.
That's right. So there must be some intermediate factor, perhaps, that the worms are producing that allows this to happen, or
maybe another bacteria.
Maybe they reconstitute with the normal bacteria.
Well, what they're thinking now is that maybe there are alterations in the microbial community.
Yeah.
So they begin to look at that, and they do, in fact, see reduction in T. murus-based reduction in Bacteroides and also Prevotella, but increases in Clostridiales. Helminth infections inhibit B. vulgatus and expand the Clostridiales. So the idea here being that the expansion of the Clostridiales, I love that word, is somehow knocking down the Bacteroides. Of course, the expansion is caused by the T. murus infection.
Isn't C. difficile a Clostridiales?
It is a Clostridiales.
So yeah, I guess when I went through this, it's great that they're using the Clostridium, but I think people then, as you say, they say that can't be good.
Right.
Yeah, right.
And so if you look at a lot of the literature, right, in the microbiome, they break it down into the Bacteroides organisms and the
Firmicutes.
right? These strong skin bugs. And the firmicutes are what we think of as the healthy ones.
Yeah.
And there's a bunch in there. Lactobacillus is in there. All the different Clostridium are in there. So don't think of the firmicutes as being so bad, because
these are the probiotics.
They're actually, these are like what's in a good probiotic, in all honesty. So, because I looked at this, I'm like, Clostridium, if you glance through this, you're going to be like, I don't want to trade my Bacteroides for a Clostridium. I'm going to end up with Clostridium difficile. And I don't think that's the case.
Only under weird conditions would you ever do that.
Yeah, because there's always going to be bacteria. It's just a question of what's the ratio of which. So we're shifting.
Remember,
that's the big lesson, isn't it?
Clostridiales is an order, right?
Right.
It contains many bacterial species in addition to C. diff, right?
So how many Clostridia species are there in the human microbiome?
Clostridiales?
Yeah.
You want me to look it up? Because I don't know the answer.
Clostridia, I mean, if you're thinking about Clostridium difficile, how many other Clostridium are there that don't come up during, let's say, stasis of the gut, for instance, and other situations which lead patients?
By the way, the Clostridia are a class of the firmicutes. That's just Clostridia, not Clostridiales.
Right?
Yeah, so the phylum is the Firmicutes.
Not notable species. That's right. The phylum is Firmicute. The class is Clostridia. And Clostridiales are orders. Let me just tell you the different species within the order Clostridiales.
Thank you.
Dickson. And then I'll get even more granular.
Oh, good.
We have Caldicobacteriaceae, Christensenaliaceae, Clostridiaceae, which you know, Defluvivitaliaceae, Eubacteriaceae, and it goes on. Helicobacteriaceae, Ruminococcaceae. Okay, and then of course among the Clostridia, there's perfringens, difficile, tetani, botulinum, acetobutylicum, hemolyticum, novi, Clostridium novi was named after Frederick Novi, Odematians. So very complicated. You got it?
Well, up to a point.
So the Clostridia are one member of the Clostridiales order. Many other bacteria in there.
And apparently they do a lot of good.
Who does a lot of
the Clostridiales? Otherwise, you'd be in trouble, right? I mean, those are the ones selected for by the helminths through type 2 immunity. So I think that's remarkable.
So the last in mouse experiment is to they inoculate mice with Clostridia, and they ask if they inhibit B. vulgatus.
Right.
And they do. They repetitively gavage mice with the mixture. And in fact, it inhibits B. vulgatus. So basically, in NOD2 null mice, in fact, the mucus response associated with type 2 immunity during helminth infection expands Clostridia, and those inhibit the Bacteroides.
Yeah.
So it's a multi-layered thing. Parasite expands, it initiates an immune response, a type 2 immune response that expands the Clostridiales, and they in turn. What a complicated ecosystem, isn't it?
Exactly.
We are all ecosystems.
I'll tell you what I have the deepest regret of now. I wish I had known this when I was a graduate student at Notre Dame working with germ-free animals.
Dickson,
It's just so many different studies.
We are all holobionts,
Definitely.
Not just coral, we are.
No, we are walking ecosystems. We're definitely there.
Now, Dickson, did you like this study in Malaysia?
Tell me again.
They have two. They have two populations. They have a rural and an urban. And the rural has lots of worm infestations.
Yeah, no, that's right.
And the urban has fewer.
Right? Exactly right. Exactly.
And I like this. We compared individuals living in urbanized Kuala Lumpur with rural Orang Asli of the Temuan subtribe.
Yeah, that's right.
Is that what you're a member of?
I used to be. I've dropped my membership.
Dropped out. You didn't pay anymore.
I didn't pay my dues.
All right, so they, one has a lot of helminths.
That's right.
And, people living in Kuala Lumpur with not a lot of helminths, they have a lot of Bacteroides, right? And the other guys don't. But that in itself could be complicated. So what they do is they treat these Orang Asli with a dewormer.
Right.
And then albendazole. And then they look at the bacterial populations. And they find that Clostridiales is the most reduced order. And the Bacteroides expand after this treatment. So you get rid of the worm and you mess up
You switch over to the bad microbiome.
guess what?
Yeah.
Great. Isn't that
The
great?
entire country of the United States is walking around with mostly bacteroides in their gut.
Yeah.
I mean, because we don't have any worms.
We don't
to
have
help us
worms.
out here.
But, there are other factors, obviously,
sure, of course.
that control it. But just this one worm can make it. Now, Dickson, do we want to have these worms in us? Like these people in Malaysia, they have them continuously.
That's the thrust of the article in the New York Times Magazine section.
Is it bad for you? Is it pathogenic?
Not a few. A few worms will not do anything to you. You won't even know you have them.
So maybe in response to Peter Hotez and bringing in Bill Gates' comment, if you're well-nourished and you have a few helminths, it may be okay. If you're malnourished, should we get rid of the helminths or should we feed you? Maybe we should just feed you and get your... So now if you're well-nourished and your immune system is competent, maybe, and I think what they're trying to say is we may want to ask these questions about, do we fly in albendazole or do we fly in food?
Well, my contention always was food, because that starts the process of healthy living. Really, drugs are just to get rid of certain things, but food treats everything.
Here's the key. At the end of the article, they say these bacteriodales, right, they're only pathogenic in people with mutations in NOD2 gene. So, if we don't have worms, we have a lot of bacteroides. It's okay because most of us don't have mutations.
You're absolutely right.
And they say many Crohn's disease patients don't have mutations in NOD2, so they don't respond to helminths.
That's right.
So this is an argument for genome sequencing. If you know the sequence of a person, they come in and they're having inflammatory, and they happen to have a NOD2, then maybe you could give them a therapy targeting this axis. Not necessarily a worm, but maybe an IL.
Something to stimulate TH2 responses.
Exactly.
That's right. So,
but there may be other problems with this shift in the microbiome, right? I mean, isn't a shift to bacteroides associated with obesity and other problems, maybe increased propensity to diabetes?
See, that's a problem. You can't just look at one thing in isolation and say, this is the solution, because there may be environmental and dietary and other genetic, right?
That's right.
It's very complicated.
So an hypothesis that just got destroyed by this article, which I love, is that the original thought was that when you give the worm back to a person who never had them before, who's suffering from Crohn's disease, let's say, and the Crohn's disease goes away, the theory was that the immune system now retargets, instead of picking on a little bit of tissue that might have some similarities to antigens in the worm, it now, there's the real target, and it goes after the worm, you see. That's not the case. That's absolutely not the case at all. So this is a secondary effect of infection with helminths.
Yes.
And it's essential to the immune system.
So the worm induces a type 2 response in the gut.
Yeah.
And that happens to get rid of bacteria, the Clostridiales, that keep the bacteroides in check. However, remember, it makes no difference unless you have a NOD2 mutation.
Right.
So, this therapy espoused in the Times article is useless if you don't have a NOD2 mutation.
You're right.
Well, the other thing that I think is a challenge, too, is this is in mouse, and in the mouse, IL-13 is important. In humans, people with Crohn's disease tend to have elevated IL-13 levels. So people have talked about using anti-IL-13. So you may just, when you transfer this to humans, it's going to be important that we isolate what are the exact cytokines, what's the pathway in humans. But it may be, again, as you sort of talked about, Vincent, the critical thing may be the shift in the microbiome back to a firmicutes, away from the bacteroides, but it may take a different cytokine to cause that shift in humans versus mice, because we're different.
Yeah. But some of the early epidemiological studies on African families versus the relatives of those people who moved to the United States was that as soon as they become worm-free in a larger population, let's say in thousands of people, the presence of autoimmune diseases goes up and food sensitivities go up, like peanut allergies and allergic responses to shrimp and this sort of thing. So the people of Africa that are related to those people don't have those food allergies. And when they go into those villages and they deworm them because of these community-based health programs, they very often now start to develop sensitivities to various food allergens, which then disappear again when the worms come back. So, again, you were confused as to what you were looking at, because it may all fit together in this kind of a story, which is a much more complicated story, I thought. So I love this article because I think it's a great start to understanding the ecology of the gut tract and how the immune system plays a role in all of this, too. And so... you're right. It's all connected.
It's nice to get a mechanism instead of sort of the hand waving.
Right. That's
right. You're immune system is bored and it doesn't know what to target.
Yeah, no, that's right.
All the anthropomorphic approaches. It's nice. This is what's going on.
It's pretty solid
and when you
stuff.
understand it, maybe we can use it to help people.
I mean,
Exactly.
the guy who wrote this article,
Yeah.
you said he's an author on this?
Martin Blazer.
No, the Times article.
Oh no, he's not he's not an author on this article at all. No, he's an amateur wormologist who is apparently suffering from one of these bowel diseases.
Does he have a NOD2 mutation?
I don't know the answer to that. I'm
If
going
he
to bring in the
doesn't-
article and show you.
if he
I just
doesn't-
on my desk outside.
Okay. If he doesn't, then worms are not going to help him.
Right.
At least these worms.
No, but there may be other mutations of who knows what. I mean, how many different kinds of inflammatory bowel diseases are there?
That's the tough thing is that we lump them, but everybody's different. We say, you have Crohn's, you have inflammatory bowel disease. But, there are millions of people with Crohn's and everyone, well, I shouldn't say everyone, we probably can break those down into the ones with the NOD mutation, the one with STAT6 issue, the one with, a different, so within, and I think that's what will happen hopefully as time goes by is we'll take each individual instead of just lumping them into a group with a million others. We'll say what's specifically your issue and how can we treat you.
So personalized genomic medicine.
Yeah, and it will become cheaper. I think it is becoming cheaper.
Yeah.
Oh, yeah, that's no problem.
Wow.
I tell you, we had my son's exome sequenced.
Oh yeah.
And it cost $25,000, which is a ripoff because these diagnostic companies are taking advantage. GeneDx is the company that does it. It's ridiculous. It should be $1,000. Now, I understand markups and all, but we didn't pay most of it, the insurance, but the insurance company, and then they pass on, to
the rest of the insurers. That's right.
Anyway, apparently he doesn't have a NOD2 mutation, so we can't give my son worms.
Well, he must have something going on down there, right?
Well, of course, but as Daniel said, there are other issues. We don't know all the genes involved, right?
Yeah.
But he has weekly issues,
Wow.
where he feels crappy, and it triggers other things,
I mean, have his microbiome been examined yet?
Not yet, but we're going to do that. But, the insurance companies won't cover that. It's not an
Hey, we're microbiologists. We can do this ourselves.
Yeah, well, it's going to be done here by the...
I've got an incubator and some Petri dishes.
Yeah, no, this is all like the ribosomal
right.
scans.
Sounds like Mickey Rooney saying he's going to put on a play in his family barn.
All right, speaking of patients...
Should we present the next case study?
Yeah, let's do that. Let me get ready here to summarize this
While
case.
Vincent
Oh,
gets
before
ready.
you do that, let me do an ad. I need to do an ad. Okay?
Absolutely.
Because we have to pay the bills,
Absolutely.
Right, Dickson? We have to pay the bills, and that gets done by Curiosity Stream. It's the world's first ad-free nonfiction streaming service with over 1,400 titles, 600 hours of content, and it was founded by John Hendricks of Discovery Communications. And they have real science shows, nonfiction, not reality TV, like the rest of TV does. And you can get it on many platforms, including the web, Roku, Android, iOS, Chromecast, Amazon Fire, and Kindle, and Apple TV, 196 countries. They have a wide variety of science and technology, so you may like it. Listening to TWiP means you probably like science and technology. But they also have nature, history, more other things. And they have interviews and lectures. Their library includes Next World, featuring Michio Kaku, talking about the future of technology, viruses, destruction, and creation, is a Curiosity Stream original. They talk about Zika virus. Microbirth, a documentary that looks at research linking the way babies are born with health later in life and leaps in evolution. A series discussing evolutionary adaptation from the origin of eyes to the creation of motherly love. Can't create motherly love.
No, but some people wish they could.
They do. Monthly and annual plans start at $2.99 a month. Less than a cup of coffee here in the Big Apple, probably everywhere else on Earth, I would guess. And if you're interested, check out curiositystream.com/microbe. Use the promo code microbe during sign-up, and you'll get unlimited access to the world's top documentaries and nonfiction series completely free for the first 60 days. That's 2 months free of one of the largest 4K libraries around. Go to curiositystream.com/microbe and use the offer code microbe at startup. No, not startup, sign up. I always say startup. We thank Curiosity Stream for their support of TWiP. All right. Time for a case study.
Yep.
Okay, great. All right, this is another recent case that I've been following here at Columbia University. It's a 59-year-old gentleman with a past medical history of childhood polio, who presented, so Vincent will like this, who presented with worsening lower extremity weakness and bowel and bladder incontinence. The patient is a construction worker who reports that about 2 years prior to him coming in to be seen by us, he started to develop worsening back pain and weakness, and it finally reached the point where he was unable to work. He felt as if he was getting progressively weaker. Now, over the 1 month prior to admission, he acutely got worse. He couldn't even walk up one flight of stairs, and that was when he developed the issue with relieving his bladder and the issue of involuntary loss of stool. The 1 week prior to admission, he says he had fever, but denies any headaches. He says no nausea, no vomiting, no diarrhea, no shortness of breath, no cough, or any other symptoms. So just 59-year-old man who has now become so weak he can't walk up a flight of stairs, and he has involuntary loss of stool.
So he lives in the area, is that correct?
So that was a good question. So you want to know where he lives.
Unde Venice.
Unde Venice.
So he splits his time between Washington Heights and the country where he grew up, which is Mexico. So the story is he was born in Mexico, but he says he's been living in the U.S. for the last 20 years working construction. But when you really get the details, is he works in the U.S. for about 2 months a year and then spends the 10 other months in a rural town in southern Mexico.
Huh.
And in southern Mexico, there's a southern region, which is where they grow a lot of the corn. So like you're in the Oaxaca region. And in the Oaxaca region, prior to, let's say, before the 20 years ago, he actually worked in the corn growing, he was a corn growing agricultural worker.
That's the origin of corn, by the way. It's from the Balsas Valley, right there. That's the absolute epicenter for where corn came from.
It's amazing how many foods came from the Americas, right? Potatoes, corn.
Yeah, that's right.
This original, you said a year before he had worsening back pain, weakness, and couldn't work. Is that a year before?
It was really back about 2 years is when he first noticed that the back pain was an issue.
And did that happen in Mexico or here in the U.S.?
Well, he's back and forth between the two.
So we can't really
pin down like exactly.
Does he have any bug bites?
Well, we're not at the physical exam yet, but we can ask him if he's been exposed to bugs. Okay. And he says yes.
He says no. He's
never been bitten by an insect in his life.
I guess if you're working in the fields, you would have lots of exposures.
Yeah. But remember now, he's in the U.S. He was doing construction during those 2 months. The other 10 months he was
in the cornfields, right?
Well, he had stopped working in the cornfields 20 years ago.
Oh, I stopped 20 years ago. Yeah. And in Mexico, what does he do? Nothing?
He hangs out. He enjoys his wealth derived from his
2 months.
Well, from his 2 months of work in the U.S. 2 months of money made in the U.S. can last you 10 months in Mexico.
All right.
And he has a son and a daughter here in the States, and he comes and visits them. And they live here in the Washington
What about his
Heights
wife?
area. He is married. He has his wife, lives with his wife. She usually stays in Mexico, but she comes sometimes.
She stays in Mexico. Okay.
Yeah, she often stays in Mexico.
Is she okay?
She's actually fine. Yeah, she doesn't no reported health problems.
So when he developed polio in the childhood, he was in Mexico?
He was in Mexico.
And did he receive therapy to restore his limb weakness?
Not really. He, this is 50 plus years ago that this happened.
Did he have any paralysis?
He did have some weakness. Yeah.
Does he still have before he got this problem? Did he have residual weakness?
He said he did. He said he had distant lower extremity weakness. He's never back to 100%.
Does he have any paralysis now?
So at this point, he has no 100% paralyzed anywhere. We'll get to his exam in a moment.
Okay.
But he's reporting like he can barely get up that flight of stairs at this point.
Does he have AIDS?
He was HIV negative. We did test that. Give you that lab value right ahead of time.
What does he like to eat?
He said most of the foods he eats are prepared in the home. So by his wife, or so he doesn't go out, eat a lot of street foods. And he has no dietary restrictions. So he eats rice, beans, tortillas, chicken.
Physical exam?
All right. Are you ready for physical?
Yeah,
Any more?
Absolutely.
Okay.
Bring it on.
So he's not febrile. His vital signs all look good. The big thing on exam is neurological. And so his upper strength is all good and symmetrical and strong. We start to run into weakness starting with his hip flexors. We do a sort of scale out of like 5 out of 5 would be full strength. So he's about 3 out of 5 in hip flexors, his quadriceps. But then as you start to get into the lower extremities, he drops down to about a 1/5 on the left and a 2/5 on the right. So, if you ask him to try to stand up on his toes, or push like he's pushing on the gas pedal, or to bring the toes towards his body, then particularly in the left, very limited strength. And as we notice, issues with his sphincter, he's losing stool. So he doesn't have good sphincter tone.
Right.
And the sensory is decreased as well.
I meant to ask about that.
Yeah. So not only is the strength decreased, but the sensory is decreased in the lower extremity. So in a sense, we say he seems to have a spinal level. We're putting a spinal level at about thoracic 9 or 10, where he seems to have deficits for things below that level.
Right.
So we're starting to think about maybe a spinal lesion being involved here.
Yep. Has he ever had a slip disc or anything like that?
He doesn't report any prior back problems or any prior trauma. He has a bunch. I'm going to give you some lab results right away.
Okay.
He has slightly elevated glucose in the 170s.
This is CSF?
No, this is just
blood
just
glucose?
blood test. His erythrocyte sedimentation rate, his SED rate, is a little elevated at 33. His CRP is 2.2. So he has some increase in those. Not huge, like we think about over 104 being an osteomyelitis or an endocarditis. So not huge, but some degree of inflammation is evident. We have a white count of 8, but we don't have a differential. Platelets, no. He has a little bit of anemia. He's at 30.6 on hematocrit. So,
And guaiac negative and stuff like that, or not?
yeah, no, it's guaiac negative. There's no blood. And so we immediately do some imaging tests, right? And the first thing we
I don't want to
image,
look.
well, it doesn't matter because I'm going
Okay.
to tell you what these
It
show.
really doesn't matter.
I'm going to describe. Well, it does matter
Because I don't know how to read
them. Yes, it does matter. I'll show you. So he gets an MRI of his spine.
MRI. Okay.
And an MRI of the spine shows the vertebrae all look normal, but at about the level of T9, T10, so thoracic vertebrae 9, thoracic vertebrae 10,
Yes.
there is signal enhancement. There's inflammation of the spinal cord, and what looks to be a mass lesion. There looks to be actually compromise of the canal. He also gets an MRI of his brain. And
Good
the
idea.
MRI of his brain shows, it's read as hydrocephalus.
Really?
Yeah. And I will say, when I look closely, I think that the parenchyma looks like there's a little bit of abnormalities there. But they don't read it. They just read it as hydrocephalus. But the tissue of the brain doesn't look 100%
He has
normal.
no headache or anything?
He said no headache.
No vision problems?
Doesn't report any.
No cognitive deficits?
Nope. No. No obvious. No.
So hydrocephaly with no enhancing lesions anywhere?
No enhancing lesions.
Even at the foramen magnum?
True. The obstruction.
I got it. Okay. That's fine.
Yeah. So it's a hydrocephalus. So there is a.
So there's
some
a
sort of-
blockage somewhere along the spinal column which prevents CSF from recycling.
Yeah, basically from draining. Because normally CSF is made up in the top ventricles, and then it's going to drain downward. So there's some sort of restriction getting down.
So this mass is presumably doing that.
How big is that mass? May I ask?
It's so we're from the MRI, we're probably talking about a sort of, I don't know, top to bottom about 2 centimeters.
2 centimeters.
The thickness is much smaller. There's not a lot of space there, but it's enough thickness that it looks like it's putting pressure and causing some inflammation to the spine.
There's a tendency to want to biopsy that, or at least go in there and take a look.
Okay.
Wouldn't you say?
Well, so I'm going to leave people at this point, and there's going to be a lot of questions like, what would you do next? What tests would you is there any, and I guess I should say, is there any other questions you have that would help to narrow down this diagnosis?
Yeah. Well, what is it like down in Mexico where he goes for 10 months of the year? What kind of animals might be?
So it's a rural area.
So pigs.
So there are pigs, there
Lots
are
of pigs.
chickens, there are
Goats,
dogs, there are
sheep.
goats. Yep.
And, these are endemic centers for malaria, for Chagas, for leishmaniasis, you think of a whole...
Tuberculosis, histoplasmosis.
Keep going.
And other endemic fungi.
High-speed lead poisoning.
Unfortunately.
Yeah, because Chiapas, that's in the area of Chiapas, I take it.
Mm-hmm.
So it's a dicey area to go back to, basically.
Yeah. Actually, there are some areas there that are not so safe.
Right. Because I remember vacationing down in Yucatan, down near Belize, and a lot of border patrols in that area looking for illicit drug trafficking and this sort of thing. So this is not a great place to go back for a vacation, I would say.
Yeah, I should make sure that we give he, interesting enough, does not drink alcohol. He's not a smoker. There's no history of drug use. He's not on any medications nor allergic to any. Just make sure we throw all that stuff in.
Right.
Now, let me ask, has he had... What about meat? When he eats meat, is it cooked?
Yeah, his wife cooks for him, so he doesn't report, eating raw, beef or anything like that, or raw fish or any raw foods.
I'm sorry.
During his stay in Mexico, is he in contact with animal feces of any kind in the fields?
Well, as we mentioned, there's livestock, there's pigs, there's chickens, there's
cows,
burros, donkeys. I don't know how many cows there are actually in the immediate vicinity where he lives. He didn't report a lot of cows. I don't think that the home in which he lives in Mexico is particularly developed, right? So, as you mentioned, there might be an issue with, are people able to fully wash their hands as in the food preparation?
Yeah.
That might be something reasonable to think about.
I'm thinking about a lot of things right now, but there are too many possibilities at this moment. But I'm sure the tests will narrow it down.
So we'll ask people, what tests would you do next to get at this diagnosis? So that's the big thing. We need to figure out what could be going on here, and how do we make the diagnosis with the least, morbidity.
Got it.
Maybe even
that is not necessarily what happened, I must add. But we want to ask our listeners, what would you
biopsy?
What would you do?
All right.
You're not going to ask us, just the listeners.
The listeners.
That's fine. That's fine, because we have a whole checklist, but it would probably be very expensive with my checklist because I want to know everything. But that's not how you do a test. You should narrow down and focus. So
that's right. Focus.
That's right.
All right. Let's do a couple of email.
There you go.
First one is from Elise, who writes in office. She writes in office, if you remember. I don't know if Dickson and Daniel know this, but she writes in often, and she lives in Lower Manhattan. And she writes, checking up on the patient from TWiP 109. Dear TWiP Trifecta, I hope this finds you well and rested after the long Memorial Day weekend. This is just the quickest note to say that I did manage to get to the Bronx Zoo over the weekend, and I looked in on the penguins at the Seabird Aviary. I couldn't photograph them because they were all swimming and refused to get out and pose, but here is proof that I was there because the brown pelicans were cooperative, and she sent this photo of herself.
How nice.
Looking at, remember being there, Dickson?
Do I? Of course I do.
They're the brown pelicans back there. I remember seeing them standing on those rocks.
Oh, yeah.
Right, so that's from Elise. So
and
now
what were the names of the other birds that were flying around, Vincent? Do you remember that?
Oh, yeah, there were these...
the Inca
Just a minute. The little gray guys with the red
gray guys
headlight.
With little macaroni...
Just a minute. Those were... I know the ones who gave the penguin the malaria were passerine birds. But these guys were somewhere in Peruvian something or others, right?
Go on.
The indigenous people
that were... birds. Those birds who were sitting up on...
Yeah, but the indigenous, the Inca...
Inca terns.
Yes, Inca terns.
There you go, because they kept turning and turning.
And then what is the one with the long beak that came up and started biting the woman's leg who was... An ibis. An ibis?
An ibis.
Yep.
The birds are cool, aren't they?
Yeah.
This morning I saw 2 goldfinches on our feet. They're really neat.
They're all dinosaurs.
They have such interesting motions with their heads,
Oh.
Mm-hmm.
So cool.
Imagine they're ancestors of dinosaurs, or the inheritors of dinosaur
Descendants, right? Yeah.
Descendants of dinosaurs. That's hard to believe, but there you go.
All right, Daniel, can you take the
Dear
next
TWiP trio and Paul.
Paul? Yes, that's Paul, right?
Right, because he's jumping in on case 109. My guess is pleural pulmonary paragangliomyces. Remember this because the patient ate raw fish and not crustaceans, and he could have been infected with paragangliomyces via contamination of eggs on fish handlers' hands. Peripheral eosinophils may not be evident in a small number of pleural pulmonary paragangliomyces cases, and lymphocytosis with T-cell predominance may be a symptom of paragangliomous infections. If patient has paragangliomys, treatment is with praziquantel. One symptom I don't understand is the high respiratory rate. I'm probably wrong in my guess, but thank you for the interesting case, Mark.
Yeah, say Mark, you can't really catch it by the eggs, by the way. So that's okay. Not a problem.
Dickson.
I'm reading. So John writes, greetings from Savannah, Georgia. I am John Mills. I received my bachelor's in biology about 6 years ago, and have been working as a GCMS analyst testing soil and water for the EPA-regulated semi-volatile organic compounds for about 4 years. Having worked in the chemistry field for quite some time, I've been interested in returning to the world of biology. Because of my strength in microscopy, I was recently given the opportunity to work for an indoor air quality testing company analyzing asbestos by PLM. Unfortunately, this opportunity fell through, but it left me with an insatiable appetite for the world of microbiology. This is when I found these podcasts. I started listening to This Week in Microbiology because at the time it was a subject with which I was most familiar, but having listened to all that were available at the time, I then tried TWiV. I then turned to TWiP to satisfy my need for edutainment. After having listened to all 3 series, TWiP is easily my favorite. There's something about the quality of interaction the 3 of you have in TWiP that I greatly enjoy. I think it helps that you all meet in person. Okay, enough for the background, and on to the main reason I've finally written today. TWiP has always been fantastically enjoyable, but it wasn't until Daniel joined the team and started doing the case studies that this podcast absolutely changed my life. The inspiration of listening to these podcasts, the void left by the asbestos testing opportunity, falling through, the motivation of my wife working on her doctorate in public administration, the 4th degree while I only have 1 bachelor's, and the sensation that I want to make a difference each and every day I go to work, have ultimately encouraged me to go back to school. I am currently seeking a bachelor's degree in medical laboratory sciences. Realistically, I don't think I would be doing it without listening to this podcast, and it was Carolyn's email from TWiP 109 that finally encouraged me to write in. I'm having to reduce my hours at my job so I can start school full-time at the beginning of June for some prerequisites, and I start my MLS coursework this coming fall. I genuinely can't wait. I don't know if I've ever been as enthusiastic about something as this. I recommend this podcast to pretty much everyone I encounter. I never could get the Springs Anatomy professor to listen. It's genuinely changed my life. Keep up the good work. I suppose it goes without saying, I really enjoy the case study segment. I would be interested to see if something could be added to the other podcasts. Thanks again for all you do. Well, that was a nice email.
Very nice. So the letter from Caroline said that it was important to give credit to laboratory workers.
Right.
On TWiM, Michael Schmidt mentioned laboratory workers are important.
You bet.
The clinical laboratory.
They're the basis for the diagnosis.
The next letter is from Peter, who sends us a link to an article. He writes, seems a bit alarming, and this article is in the Courier Mail. Flesh-eating tropical bug sweeps through the Middle East after thriving in ISIS strongholds. It's cutaneous leishmaniasis.
Oh, yeah.
See that, Dickson?
I do.
I don't know why it's purple. Is that because it's being treated or something?
I have no idea.
Yeah, everybody's...
It might not be a case of dermal leishmaniasis either.
It's not good.
No, it isn't.
These poor kids are all young with lots of lesions.
That's what happens when you have no organization. It's all chaotic in those situations. And as a result, there's no medical care. There's no daily checkups. There's no...
Yeah, these are camps, basically, where people are living
it's really awful.
Bad situations.
It is.
Cutaneous. Look.
Totally agree.
Very bad.
Yeah. No, it's a tragedy.
All right. Alan writes, Dear Doctors TWiP, it's a hazy, hot 41C 106F here in New Delhi. but a more sane 22C72F in the airport transit where I find myself waiting for the fifth and last leg of a milk run journey to Kathmandu.
Nice.
What's a milk run journey? What does that mean, Dickson?
I guess it means that they've made a lot of stops along the way.
Well, he works for University of Nations Global Health, so maybe he's up there to be helpful in some way.
Yeah, maybe. Just to get a guess in, I'm going with an ectoparasite, bed bugs. Okay, so that's last week.
Right.
Both the sudden appearance overnight and the lack of appearance in flexure surfaces rules out scabies. Flea bites are smaller and more randomly diffuse rather than large, hard, and often linear bites. Both bed bug and mosquito bites can appear as raised, hard, itchy bites, but bed bugs bites typically are in areas of the body in contact with the mattress. Ticks and chiggers more often locate where clothing is tight, like a waistband. You always would want to rule out a food allergy or contact dermatitis. The once-a-week linear abdominal rash has all too often been a high-nickel Boy Scout uniform belt buckle. Huh.
I like that.
Bed bug
You get a
bites.
badge for that?
Yeah, right. You should make a badge. Bed bug bites tend to last longer and even look more severe than mosquito bites, which most people can self-identify, causing them to be more alarmed. After a week of penguin parasites, I'm guessing this is simple bed bugs. Of course, I'm always happy to hear about a new zebra chase, which makes your collaboration so delightful. Keep up the good work. All right, Daniel.
Anthony writes, on the recent TWiP that you criticized the current widespread fascination with food, I too have found this disconcerting, yet another sign of the deterioration of the American mind. With the rise of the cooking channel and the other media focus on food, I recalled an anecdote of a patron of a tavern that I ran in Jersey City. He says PG, pre-gentrification. The gentleman had been all through the New Jersey penal system. As luck would have it, often in the company of Hurricane Carter. You guys remember the hurricane?
I do.
Sure,
I do.
absolutely.
Yeah, he related how in prison, no matter what program was put on the common room TV, an argument would break out for others almost always wanted to watch something else. The exception was The Galloping Gourmet. Every inmate watched this with fascination. He found this especially curious because, though not fancy, there was no fault with the prison fare either in quality or quantity. Okay. And this is Alberto.
Alberto writes, gentlemen, I believe the greatest compliment I can pay you for your excellent educational service is to plug in your podcast and expose my emergency medicine colleagues to your entertaining and informative podcast. Besides writing a monthly article for Emergency Medicine News with my wife, Jordana, also an emergency physician, I'm also a novelist. I'd love to send you an autographed copy of my latest medical thriller, Dr. Vigilante, soon to be a major motion picture. As a small token of my appreciation for everything you do, please send it. Thank you, and keep up the fantastic work. If I read it, I'll make it a pick of the week on This Week in Virology.
He's an emergency physician in Las Vegas, Nevada.
All right.
And he's the author of Dr. Vigilante and the preteen urban fantasy series, The League of Freaks. Wow. So he sent an article in Emergency Medicine News where he plugged TWiP. He said, if you like parasites, you will love TWiP.
Oh, that's nice.
A podcast all about the noxious critters that wreak havoc in the human body.
There you go.
There you go. He plugged us, Dickson. You see that?
Yes.
Are you beginning to realize the
Vincent, I
power
told you
of TWiP?
when I
Dickson?
came back from my trip to Amsterdam, I came back filled with listener comments over there telling me how much they enjoyed our banter and our information, too.
I guess you're getting it. All
So,
right.
yes,
We have
totally.
two more. Let's do the two more that we have. Anthony writes, Glasgow Romans ate porridge but suffered worms and fleas. He sends an article in the Scotsman, which is about this Roman soldiers stationed in Scotland nearly 2,000 years ago dined on porridge, figs, coriander, and wine, but were infested with parasites and fleas, according to a new book analyzing archaeological evidence. These are excavations of a large Roman fort in Bearsden, Glasgow.
Serves them right for being up there to begin
We
with.
were very fortunate to discover sewage in a ditch, which was analyzed by scientists and demonstrated that the soldiers used wheat for porridge and to bake bread, possibly to make pasta. It also told us they ate local wild fruits, nuts, and celery, as well as importing figs, coriander, and opium poppy from abroad, and that they suffered from whipworm, roundworm, and had fleas.
Nice.
All right, one more, Daniel.
Okay. Dear TWiPers, this is Lori writes, The term June gloom pertains to a coastal California event. During the summer months, the fog comes in and doesn't burn off until about 11 a.m. This creates a gray, gloomy day until the sun comes out. I really enjoyed listening to all of your podcasts.
Lori is
Where's the doom part?
Lori's
the gloom I got.
Lori's an infection control nurse. Now, I think in the last episode, someone had written in about the San Diego gloom, June gloom. He said it finally is lifted. Anyway, I didn't know what it was. So she explained it to us, so I appreciate that. Thank you.
It's a good thing they don't live in Lima, Peru. It's there every day.
Is that right, Dickson?
Absolutely.
You could go there.
I was there, and Daniel was there too, and he'll agree with me that there's a fog cloud that comes in, it doesn't leave.
So I used to, when I was more climbing, I would hang out with a lot of, we called them transients, people who did not necessarily live in a permanent place. Maybe homeless is what
Just
people in New York.
Through.
And they would complain that was a real problem when you wanted to be a transient or homeless person in Northern California. This fog, everything was wet. It was just unpleasant.
And all the wine and the avocados. And
I don't know how much wine and avocados this gentleman was enjoying who communicated this, but.
Right.
This has been TWiP. You can find it at iTunes and also at microbe.tv/TWiP. Think about becoming a patron of TWiP if you like what we do and all the other shows of Microbe TV. Many of you like them all. You can become a contributor, a patron of the arts. You can give as little as $1 a month. Go over to patreon.com/microbetv. Or if you don't like this idea of subscribing, you can give us a little bit of money via your PayPal or credit card. You can go to microbe.tv/contribute. Now, you may want to know, why do you need some money? Well, we would like to do more. We'd like to travel a bit more. We'd like to do different types of shows that require some help. I'd like to, in fact, hire someone to help me do the production here at Microbe TV. It's all for advancing the shows. It's not for paying anyone, even though Dickson would like to be paid.
No,
We're not going to pay him.
I'm
big bucks.
wealthy in other ways.
Dixon wants big bucks, but he's not going to get it from Microbe TV.
No, he's not.
All right, so you have questions and comments. We know that you do. Please send them to TWiP at microbe.tv. Daniel Griffin is at Columbia University Medical College.
Center.
Why did I not know that? I've been here 35 years. LLC. Thank you, Daniel.
Oh, thank you. It's always a pleasure.
Although I think it's going to be renamed, right, Dickson?
I do think it's going to be renamed. It's heading in that direction.
All right,
There's
good.
no question.
Dickson Despommier is at Racaniello.org. Thank you, Dickson.
You're welcome, Vincent.
And verticalfarm.com.
Yeah.
And we're going to work on your website when I get back, right?
That's right. 2 of them. I've got another one that I want you to see.
We can do 10.
We could do 10.
All I need
Parasites
is
Without Borders, right?
And we got Parasites Without Borders coming up, and we've got some news to announce about the 6th edition of Parasitic Diseases, which I think is quite exciting.
All right.
And we might be able to post something next time.
Okay. And next time will be in about 4 weeks. I'm Vincent Racaniello. You can find me at virology.ws. The music you hear on TWiP is composed and performed by Ronald Jenkins. You can find his work at ronaldjenkins.com. You've been listening to This Week in Parasitism. Thanks for joining us. We'll be back soon. Another TWiP is parasitic.